All right, we'll go ahead and get started. Thank you to everyone who has joined us from all over the world for this very important webinar from the American Society of Echocardiography. The current coronavirus pandemic has changed our lives, perhaps permanently. As healthcare providers, we are at the front lines in the battle against COVID-19. This webinar will focus on how we, as echocardiographers, can be prepared in our practice, in our labs, to optimally protect our patients and ourselves with best practices in this crisis. We have convened a panel with expertise and experience to discuss Ecolab preparedness. I'm Madhav Swaminathan, current ASE president. I'm joined by Dr. James Kirkpatrick, cardiologist from the University of Washington in Seattle, Professor Anita Sadeghpour from the Shahid Rajai Cardiovascular Medical Center in Tehran, Iran, and now Duke University, who brings experience from her Iranian colleagues. And Captain Daniel Chertow, tenure-track investigator and head of the Emerging Pathogens section at the National Institute of Allergy and Infectious Diseases in Bethesda, Maryland. We're also joined by ASE staff Liz Lane and Christina LaFuria, who were instrumental in organizing this webinar and will be at the back end, making sure that all the questions are entered in the Q&A box and making sure that we get everything organized towards the end as well. So don't forget, you can ask questions by clicking the Q&A button at the bottom of your screen and entering your query. I'll be collating these responses and posing the questions to our panelists at the end of their presentations. We may not be able to get to all your questions, and we may not have all the answers either, but together we hope to address as many queries as we can and share experiences to improve preparedness in our echo labs. I'll remind you that the recording of tonight's COVID-19 webinar will be available first thing tomorrow morning, and you'll also find it on ASE's YouTube channel, ASE University, ASE's website, and the Open Forum of Connect. We'll also email it to everyone who has registered for this webinar. What we will do is we will start with Dr. Jim Kirkpatrick, who will give us an outline, and then we'll transition one by one to the other speakers and panelists as well. And we'll hold for questions towards the end, and we leave some time to answer all of your questions, and we'll try and get to as many of them as possible. And if you have any questions, just add them in the Q&A box. But if you have any issues with technical issues, for example, you can always put it in the chat box, which is also being monitored. Thank you so much, and I'll turn it over to Jim.
Thank you very much, Dr. Swaminathan. If we could have the next slide. I want to go over the outline of what we're going to be discussing this evening. We're going to talk a little bit about the background to get us all on the same page and the global situation. We'll ask Dr. Chertow to do that. Then we're going to talk a little bit about potential cardiovascular involvement in COVID-19 to set the stage for some of the things that we're going to be talking about in terms of protocols for echo. And then we're going to follow the recent statement that we put out from the American Society of Echo on whom, where, and how to image patients and image in general in this time of COVID-19. We're going to go over some recommendations for protocols, protection, and then talk about some other considerations. So first off, let's turn it over to Dr. Chertow.
So thank you very much. It's my pleasure to be here tonight. And we're going to be speaking about coronavirus disease, a global pandemic. Next slide, please. Our learning objectives are to review the biology of coronaviruses and then to discuss coronavirus disease 2019, providing an overview of the biology, epidemiology, pathogenesis, clinical manifestations, and infection control, as well as ongoing public health measures to limit spread. Next slide. So coronaviruses are spherical enveloped positive strand RNA viruses. There are 4 genera, including the alpha, beta, delta, and gamma viruses. They have a wide host range in animals, and the alpha and beta viruses commonly cause respiratory illness in humans. Shown here is a schematic of these viruses, emphasizing the 4 primary structural proteins that make up the virus. Next slide, please. As previously mentioned, there are 4 human endemic coronaviruses that are shown in black here that circulate year in and year out and are thought to account for 15 to 30% of common colds. Beyond those, there are 2 known severe human coronaviruses before the current epidemic, and those include SARS coronavirus, which caused an epidemic in 2002 to 2003, resulting in over 8,000 cases and over 7,000 deaths, as well as MERS-CoV, which was recognized in 2012, that has ongoing spillover events into the human population that do not result in sustained transmission. And that's accounted for more than 2,000 cases and 800 deaths globally. Next slide, please. And that brings us to December of 2019, when a cluster of pneumonia cases was reported from China to the WHO. And individuals shared a common exposure to a local seafood and animal market. And within a short time frame, a novel coronavirus was isolated and termed SARS-CoV-2. An electron micrograph of that virus is shown here. The genetic sequence of that virus is most similar to bat coronaviruses. Next slide. Since that time, SARS-CoV-2 has caused a global outbreak. Shown here is the current WHO situation report, where more than 170,000 cases have been reported globally, with more than 7,000 deaths. And as you can see, those cases are increasingly spread across the globe. Next slide. While the outbreak started in China, cases are rapidly rising in countries across the world outside of China. And the graph to the right shows the WHO graphic that's now a week old and certainly is different at this point, where cases in Europe and other parts of the world are increasing. In the United States, we've had more than 7,000 cases in all 50 states, including the District of Columbia. Next slide. Based upon the large cohort from China, we know a little bit about the age-specific case fatality rate, and as has been mentioned, the individuals that are older age have the greatest risk of death, with those that are 80 years and older having an estimated case fatality rate of 14.8%. Next slide. So regarding transmission, the initial spillover is thought to have occurred from an animal reservoir to an intermediate host and ultimately into humans. And since then, human-to-human spread has accounted for the spread of the epidemic. Spread is thought to be attributed largely to large respiratory droplets, and that's vis-a-vis coughing, sneezing, or speaking in close proximity to a person who's infected, or by fomites, which are contaminated surfaces. It is known that the airborne route is a possible route of transmission, but that is thought to be predominantly in the setting of aerosol generating procedures. Which brings us to the CDC guidance on personal protective equipment for healthcare workers caring for COVID-19 patients. And the guidance can be found at the website at the bottom of this slide. That guidance suggests that the minimum requirements for patient interactions include gloves, gown, eye protection, and a surgical or a medical face mask. For those that will be participating in aerosol generating procedures, an N95 mask is recommended. And these recommendations, as the epidemic moves forward, will ultimately have to balance risk with potential scarcity for personal protective equipment. Next slide. So SARS-CoV infects cells within the airway. As you know, it progresses to pneumonia, and severe lung injury is possible. There is a viremic phase, and ultimately direct or indirect injury to multiple organs throughout the body have been observed. Next slide. These are clinical findings from the first cohort of 41 hospitalized patients in China that simply emphasize that common initial symptoms include fever, cough, and lower respiratory tract symptoms, including dyspnea and tachypnea, which are associated with more severe illness. Next slide. And these are some chest CT findings that are fairly typical of both early disease course on the left and later in the disease course, where multifocal lobar consolidations can be observed. Next slide. A little bit about the timeline of illness. We know that there's an approximate 5-day incubation period before symptom onset. We now know that shedding can take place before onset of symptoms, and that between days 7 to 10 is the interval when respiratory failure typically occurs. Next slide. So the current public health measures to limit spread in the United States include travel restrictions and screenings, case isolation, contact tracing and quarantine, and now widespread social distancing for the purpose of flattening the epidemic curve. Additionally, vaccine and therapeutic development is ongoing. Next slide. So in summary, SARS-CoV is a new human coronavirus. It spreads efficiently from human to human. We believe, based upon existing data, that the case fatality ratio is less than 2.9%, but this is an evolving outbreak. And given that, clinical and epidemiologic updates can be expected, and preparedness and response is warranted. Thank you.
Thank you very much, Dr. Chertow. And now we're going to turn to Anita Sadeghpour from Iran to tell us a little bit about the cardiovascular involvement and also the experience that she has had in Iran dealing with COVID-19.
Thank you so much. It's a pleasure to be part of this great group. So next, please. First of all, I would like to send my deepest sympathy and respects to those colleagues all around the world who are fighting against the coronavirus infection, and those who served for the care of these patients and unfortunately passed away. They are heroes. Next, please. Until now, Iran ranks third among all countries for the total confirmed cases of the coronavirus after China and Italy. Although the number of the infected patients is still increasing, the good news is that in a short period of time, many local and national protocols have been prepared for the healthcare providers. And my colleagues in the Iranian Society of ECHO, also they've done a great job and prepared the national protocol in Persian language for protection of the ECHO lab personnel. Next, please. And till now, as I've been updated, none of the ECHO lab personnel who followed the PPE and the protocol for protection, none of them have been infected with COVID-19, which is a great news. And here is a clear message. COVID-19 is a serious disease, but it shouldn't be scary for the healthcare providers if they follow the recommended precaution protocols. We should accept that the life is different at the time of corona and need to pay attention to everything that could transmit the virus. Next, please. This is a bulletin from the ACC with the clinical guidance and very useful for the cardiovascular care team. Next, please. So for the outpatient clinic, usually we screen the patients based on the history to the travel for high-risk regions, or if they have had a close contact with a confirmed case of COVID-19, or they report symptoms or display signs of lower or upper respiratory tract infection. However, we know that the most common symptoms are fever, cough, and shortness of breath. Based on my local experience from my colleagues, the loss of appetite and severe fatigue are also very important, and sometimes these are the major symptoms for these patients. Next, please. So what are the potential indications for the echocardiography for patients with COVID-19? We knew that dyspnea is a common symptom in these patients. So there is a possibility that such patients would be referred more frequently for echocardiography. The following patients may benefit from TTE more: patients who have the symptoms of the heart failure, patients with significant arrhythmia, patients with significant ECG changes, patients with cardiomegaly in chest X-ray, and patients who have the more than mild pericardial effusion on chest X-ray. on chest CT. More importantly, patients with previous heart disease and suspected or confirmed COVID-19 may benefit more when the hemodynamic status of these patients or signs and symptoms are disproportional to lung injury. And the patients like the patients who are in undifferentiated shock. So these are the indications that mostly patients will benefit from the echo in COVID-19. Thanks.
Thank you very much, Dr. Sadeghpour. If we could have the next slide. I'm going to talk a little bit about what we have seen in Seattle. This is where we are in the state of Washington. Next slide. Currently, these are the active cases that we have as of about an hour ago in Washington state. They're covered cases and also the fatal cases. Obviously, a lot of people are still in intermediate category at that point. And as with Dr. Sadeghpour, I would like to express sympathy with all of the healthcare providers who are involved, but also the grieving families, the patients, and the loved ones that are actually facing quite a bit of uncertainty and suffering as their patients are actually admitted with these diseases or are suffering from them. Our primary mission, I'd like to remind everyone, is to continue to provide excellent and compassionate care for patients. This is clearly more challenging in this day and age, but we need to keep that in mind. Next slide. This is the ASE statement that was put out yesterday, and it covers a number of different things that I will be talking about. I would recommend that everybody take a look at this, but I do want to mention one important caveat, that the rules and recommendations and local protocols that are being developed as we speak are changing very rapidly and appropriately so in response to new developments and new data that's constantly coming out. Next slide. So to get into our who and where and how to scan, starting with whom, the first thing I think that should be somewhat axiomatic is that we want to apply our appropriate use criteria. We don't want to be performing echocardiography studies on patients who will not benefit from them. That's true always, but it's particularly true in this day and age. And I think we should all take the opportunity to look back at the appropriate use criteria and that will help guide us to determine whether this study is going to be useful. Just sort of the main things that back up the criteria are the idea that we really should have a clear clinical benefit that is achieved in doing the study, or that it should change management. And also we should be avoiding repeat studies that are really done for no particular reason. Next, we'll talk a little bit about ideas of how to postpone or reschedule studies. There are different ways to look at this. One would be to identify elective studies and not do them. And then other times are to identify studies that are clearly not elective. It's basically two ways of looking at it from sort of different directions. But they should basically arrive at the same conclusion, that we want to be doing studies that are going to actually give some benefit and that cannot be postponed until a better time, perhaps when the infection has died down. What we are particularly doing at the University of Washington in guiding our decisions about this is we're asking ourselves, in the next month, is there substantial risk for morbidity, mortality, suffering of the patient, or access of the healthcare infrastructure that might be avoided by doing an echocardiogram? We certainly are facing quite an onslaught of patients, and the more people we can keep out of the hospital in this difficult time, the better. We're also thinking about the crisis setting, and some countries are already there. Currently, we are in a more of a contingency setting in which we are actually making decisions to try to conserve resources, but we are basically applying the same standards of care, maybe a little bit differently, but keeping our best practices in place. Crisis settings are different. That's when we may have to think about triaging and prioritizing who gets what study or who gets the study when ordinarily we would just do it. And in some cases, there are going to have to be some very difficult decisions made. These should be done in consultation with the ordering clinician, who often has much more background information and important information that could be used to make these decisions than we do in the imaging laboratories. The fourth point that we need to make, as has already been mentioned, that the risk for aerosolization will change how we practice, and TEEs are high risk for aerosolization. So we should be asking ourselves if maybe there's another way to get the information that we'll be getting from a TEE, perhaps off-axis or additional images by transthoracic, using ultrasound enhancing agents, also known as contrast, microbubble contrast, might be able to give us that information. Or perhaps there's another imaging modality that does not involve the same risk of aerosolization. Next slide. Where to scan is an interesting question. Obviously, we like to be able to bring patients to a place where we can use our cutout beds and be in an environment that gets us the best images. But when we think about the risk of transmission that can happen during patient transport, it argues very strongly that patients should not leave their room. And echocardiography, also really all forms of echocardiography, including dobutamine stress echo, and perhaps even a bicycle stress, if you have a portable bicycle, can be done in the patient's room. And therefore, this is a very powerful technique, and it does help us to avoid the risk of transmission. The other things that one should think about is perhaps dedicating certain machines to be used. We have set aside some of our older machines that we are going to be using pretty much exclusively in patients that are COVID at risk or that are actually confirmed for it. In the outpatient setting, it is a good idea to think about setting aside a special room. This is a picture of our scanning room that we've actually set aside for patients who come in and need to be scanned as rule-outs or confirmed cases. Next slide. How to scan involves both protocols and protection. When we're thinking about protocols, we want to think about standards for urgent and emergent decisions. And as we said before, but this may actually be different for transthoracic stress tests and transesophageal echoes. And of course, that's all subject to change. An important point to make is that echo is involved in a lot of research studies. Most of these are elective, and they probably should be rescheduled until a better time. The research studies that are going on in COVID-19 patients have to be balanced against the personal protective equipment use that are involved in doing these research studies, and of course the infection risk transmission to research sonographers that are raised by performing these procedures, and those must be balanced with the information that we're going to be getting out of those research studies. So let's move on to the next slide. An important, perhaps, first step in thinking about scanning patients and how we're scanning them is the use of POCUS. POCUS is defined in many different ways, but the basic idea is that the person who is caring for the patient and doing a physical exam on the patient is actually doing the scanning. So if somebody has to be in the room anyway, they should, and they have the requisite skill in acquiring images, they should probably do so, and that will give us a lot of information going forward. This could be an initial screen, could diagnose the patient with a cardiac involvement or cardiomyopathy, could help to triage where the patient actually needs a full feature echocardiogram, and certainly when the echocardiogram is performed, the images that were obtained at the bedside by a POCUS user could help guide and limit the amount of exposure the sonographer will have when doing the transthoracic echo, or if a TEE or stress test is done. And of course, there is a great potential to be able to monitor and follow up cardiac function over the course of the hospitalization. Furthermore, there are opportunities to use these small devices. Even if someone is not particularly skilled at using it, they can be guided remotely with some of the new technologies that are available for these by sonographers that are watching both the person's hand and movements and also the screen to help them get the best possible images. I've included a video clip here of scanning the lung using ultrasound, which many of you have probably already seen. And this is demonstrating those very bright lines down the screen. And they are B lines. Basically, they can show when there is interstitial and intralobular edema that can be happening in the setting of an ARDS picture or pulmonary edema. It can be very helpful. And of course, using this might obviate the need to expose an X-ray technician to the COVID-19. Next slide. So I want to go through one of the figures that we have in the document, and I'm sorry that this is not actually displaying correctly here. But at the very top of the screen, as we mentioned already, the first step is to determine whether an echo is indicated and is indicated at this particular time to consider deferment or reschedule if not. If it is, then we would obviously like to know what the COVID status is. If it is suspected or confirmed, then that puts us into a different category than if it is not. If it is not, then our standard precautions are followed. We are following fairly strict droplet precautions for all TEs, even those that are normally done under standard precautions in this day and age. If COVID-19 is suspected or confirmed, we at least are treating these the same. And essentially for transthoracic and stress echoes, we're doing droplet precautions in every portion of the hospital that is not the ICU. In the ICU, in operating rooms, and of course, if the patient is ventilated, either invasively or non-invasively ventilated, increasingly we're not using non-invasive ventilation because this tends to spread the virus even more than mechanical ventilation through an endotracheal tube. Then we would use airborne precautions, and we'll talk about that a little bit. We are also doing airborne precautions for all patients confirmed or suspected COVID-19 who are undergoing a transesophageal echocardiogram. This is, of course, subject to change as we learn more about viral transmission. There also are some other specialized considerations, including protocols involving POCUS as sort of the first look, and of course, focused imaging that we'll talk about a little bit later, time allowing. And then we'll talk about protection, the specifics of it, but essentially one should also give consideration to excluding all non-essential personnel. What this might particularly mean is no students will be scanning patients who are suspected or have COVID-19. And then limiting the exposure of those who are elderly, chronically ill, immunocompromised, or pregnant might be a good idea. Local protocols vary quite a bit at this time, but it's certainly something to consider. Next slide. So what, if anything, should we be looking for on an echo in patients with COVID-19? Is there a COVID echo? Well, I think you could make an argument that you certainly want to look at some of the aspects that we know have been reported in patients with COVID, but I would rather that we think more about fit our echo imaging to the clinical situation. So rather than doing a complete study on everyone, we do it when it's appropriate, and otherwise we look at the background of the patient, we look at their presentation, their symptoms, prior imaging, including POCUS, and then we fit our imaging protocol to that particular patient. This does mean planning ahead, but I think that might be the best definition of COVID echo. Next slide, please. How to scan? Well, we're going to talk mostly about protection, both the personnel and the preservation of equipment. Next slide. This is the website from the CDC, which has a lot of excellent information in terms of limiting infection spread, and I would recommend everybody take a look at that when you get a chance. Next slide. Here is a table that we developed in the document that goes on, it just deals with the different aspects here. Hand washing should occur all the time, as we know, and we are recommending that gloves or double gloves be used in all situations as well. Isolation gowns are normally not required in standard procedures, but certainly in special droplet and airborne procedures. A surgical mask is somewhat controversial. Some people would use it standard in all situations, and the CDC has actually recommended, as Dr. Chertow mentioned, that it is appropriate in droplet. Now, is it as good as the N95 or N99 respirators or the PAPR systems? No, but we are trying to conserve those resources at this point. So certainly those would be appropriate if they're available and don't need to be conserved in a special droplet situation. But at the current time, surgical masks are probably appropriate. So clearly you want better protection in N95 and N99 and PAPR systems, which I'll show you a picture of in a moment, in airborne situations. Face shields should be involved in special droplet and airborne. Surgical caps and shoe covers are other areas that one could consider and probably should in these settings. Next slide. This is a picture of the PAPR or powered air purifying respirator if you haven't seen one yet. Next slide. This is the N95, N99 respirators. Next slide. And of course, this is the standard surgical mask. Next slide. This is very helpful. depiction of how one should don and doff personal protective equipment from the CDC again. It shows you how to put on the gown, the mask or a respirator, the goggles, the gloves. Next slide. And equally, or perhaps more important, how you should actually take them off. I won't go through this, but it is a very helpful resource. Next slide. In terms of personnel, we already talked about the limitations on certain staff members that could be considered. And the other thing that we have to think about is limiting the exposure time. And for many of us, that will mean not performing measurements in the room on the echo machine. Now, sometimes echo machines are the way that we do the measurements. We don't have PACS workstations to do that on later. But these measurements, though they need to be done, should be done outside the room. They do not have to be done at the time. We should limit our time in the room and limit that exposure. Next slide. Cleaning and disinfection, basically follow the manufacturer's recommendations, and all of them have them easily available on their websites. An important point is that when you're coming out of a room, cleaning once is not enough. What we do is to clean in the room, we then move the machine out of the room, and then we clean it again. This is, I think, somewhat recommended practice, but certainly what we're doing right now at the University of Washington. The other thing to remember is that you should allow there to be adequate wet time after the equipment is wiped down with wipes. And these vary between the different types of wipes that you could be using. This reference here for the American Institute of Ultrasound Medicine gives very important guidelines for equipment disinfection and more specifics. Next slide. Please don't forget your reading and work rooms. Workstations also need to be wiped down. The keyboard, the mouse, the desk, the chair, the phones, and the doorknobs. And of course, you should attempt to reduce traffic in the echo lab at these times. Practice good social distancing. A lot of times this will involve actually having people do remote consultations. So rather than coming to the echo lab to view the images, they should probably look on the images remotely or just discuss them over the phone. If they do show up, obviously try to keep them 6 feet away from you. Next slide. Next slide. So at this point, I'll turn it back over to Dr. Swaminathan for any questions that we have.
All right, thank you to all the panelists. Can you all hear me okay? Good, because there was some questions that came in the beginning that they couldn't hear properly. So there have been a bunch of questions coming in. So first of all, thank you to all three of you for fantastic presentations. There are a bunch of questions that have come through, some through text and some through email and some through the Q&A chat function. So I'll try and sort of split this up a little bit. I'll refer the first one to Dan Chertow, and I'll tell you a bunch of questions are on the personal protective equipment and the cleansing of stuff, but there's still lots of categories. So what I'm going to ask is, Dan, there was a question about reinfection rates, and there's been some report out of Japan, I believe, that there was one patient who got reinfected after the disease. So can you talk about something, can you say something to that?
Sure. I mean, I think the answer is that we don't know yet. We're still sort of in the situation of individual case reports and others, but the answer is we don't know. What we do know is that that after an individual has recovered from SARS-CoV-2, that clinically is improving, et cetera, that they can have shedding of viral RNA from their respiratory tract for a somewhat extended period of time, perhaps up to a week or longer after they've had clinical improvement. But defining whether that shedding of viral RNA from the lower respiratory tract correlates with infectious virus is not yet determined, but is something that that is being looked at and that will be determined as this outbreak progresses. But as far as the question of the potential for reinfection, it's too early to tell.
Right, thank you so much. Several questions on aerosolization risk. There's one question about the recent paper from New England Journal, showing that the virus remains aerosolized for over 3 hours. Do we need to shut down an echo room for that after a suspected or confirmed patient has had a TEE, assuming it's not done in the patient's room and it's done in a separate room? But if it's aerosolized and it stays for over 3 hours, how do we address a location like that? Now, I'll leave that open to either Jim or Dan, whoever wants to take that.
Early on, we were doing a deep cleaning on all rooms where suspected or confirmed patients were in, so that would be shut down. I think that by necessity, we may going to have to relax that at some point, but I would be very interested in what Dr. Chertow has to say and give us guidance on that.
Sure. No, I think these are natural and good questions. There is a spectrum of transmissibility of respiratory viruses from somewhat transmissible, to highly transmissible. And if you were to choose two viruses on that spectrum, on one side you'd put the influenza virus, and on the other side you'd put the measles virus. And if we use one specific term to characterize transmissibility, that would be the reproductive number of a virus. And the reproductive number of a virus is the number that an infected individual on average goes on to infect. How many other individuals does that one person go on to infect? And just to give you an idea, in an otherwise non-immune population, that number for influenza virus, on a seasonal year is around 1.2, less than 2. Whereas for measles virus, that number may be close to 12. Where measles is a true virus that's passed via small droplet aerosol, sub 5 micrometers, and that stay in the air. The early estimates of the reproductive number of SARS-CoV are in the 2 range, so 2.3. It's another way of saying that the current evidence supports that the primary mode of transmission is large respiratory droplets by coughing, sneezing, talking in close proximity. It's not to say that small respiratory droplets cannot transmit the virus, which is the concern about aerosol generating procedures. In those situations, you can generate those small droplets. And based upon prior outbreaks with SARS-1 and MERS, we know that healthcare workers that engage in aerosol generating procedures are increased risk of transmission. But that's not observed outside of that spectrum of procedures. And those procedures are generally thought to be intubation, endotracheal intubation, perhaps non-invasive mechanical ventilation, bronchoscopy, and a number, transesophageal echocardiography obviously would fall into that category. So we have to be careful not to confound studies that look for survivability with the environment with what we understand about the clinical and epidemiologic features that tell us about risk of transmission depending upon the different activities that we're doing at the bedside.
No, these are great points that both of you have made. Regarding, because a lot of questions have come in about this, the difference between droplet and airborne precautions, especially relating to aerosolizations, because that's a solid concern for all healthcare providers. So one question, a couple of questions on aerosolization actually. So one was that if a patient has a cough, is that considered an aerosolization risk, and is a surgical mask, for example, on the patient sufficient to prevent transmission? And the other thing is that, and this perhaps for Anita or Jim, is that all these TE machines and echo machines have fans. And how does the working of the fan to cool down the machine add to the aerosolization risk? So I'll start with Dan, perhaps, on the cough patient mask issue.
Yes, and you can imagine where there can be confusion around this between quote unquote large droplets versus quote unquote small droplets, and we usually use the concept of 5 micrometers as the differentiating feature, where less than 5 micrometers is a droplet that's desiccated. It can dry out and it can survive on the little eddies, the little waves of air, and stay in suspension for an extended period of time. the coughing, the talking, that type of thing, that is thought to be large respiratory droplets that fall out of the air within 6 feet. So based upon that concept that has been tried and true with, other respiratory viruses, the recommendation for interactions that don't generate small droplet aerosols is a minimum of a surgical mask. Now that's the recommendation as a minimum. That's not to supersede individual facility recommendations, where if the decision is to go higher based upon availability, there's no recommendation against that, in which case you can put on an N95 mask. But the concept of risk and scarcity are important ones that have to be weighed as it relates to choice of PPE as a function of the procedure and the interaction, the risk of that procedure and interaction.
Yeah, these are important points. I'm going to switch gears just a little bit and move to a couple of questions for Anita. Some questions have come up on the cardiac involvement, and specifically one was how to rule out heart failure in a COVID patient without echo if physical exam and biomarkers aren't reliable. So the question, how reliable are biomarkers and alternate methods to diagnose heart failure?
So it's not just the biomarkers, the ECG changes. As we are thinking about the primary involvement, such as the myocarditis, the patients have some symptoms like the chest pain, which can be with the dyspnea, and there is some ECG changes, and the elevated markers such as the troponin and BNP, which is really elevating. These are together can be a marker for the myocardial involvement. However, we know that in the severe cases, because of the hypoxemia, there is a possibility that the heart can be involved, but that's the secondary involvement. For the primary involvement, the raised, elevated, like the troponin and the BNP, and the ECG changes, and the patients who have the chest pain, and even in the chest X-ray, the cardiomegaly can help. So before before doing the echo.
Right.
Can I show you the some slide in this regard? Can you go back a few slides? No, more back, please. So this is a case. Next, please. Next one. So this is a patient. Who had the fulminant myocarditis. Next one, please. And this is the only case report for the fulminant myocarditis, and the patient had the cardiomegaly and the highly elevated troponin, MB, and the BNP. Next slide, please. So the patients came with the chest pain and dyspnea, suspected SC elevation, and normal coronary CT angiography with highly elevated troponin T, CPK, MB, and BNP. So even in the chest X-ray, the LV was mildly enlarged. So before the echocardiography, the patient's symptoms was different from the dyspnea and the typical features of the patients with COVID-19. So this patient had the myocarditis, which was more prominent than the lung injury. And after the treatment, the patient's the heart failure returned to normal, and ejection fraction returned to normal from the 27% returned to 45% to 50%. So the symptoms for the chest pain and the cardiac enzyme are more prominent, and the echo would be very helpful.
So one thing I would just caution everyone, remember heart failure is a clinical diagnosis. A low ejection fraction or even diastolic dysfunction does not mean that a person has the syndrome of heart failure. It actually does involve looking at the entire picture of what's going on. And etiologic involvement is certainly important to try to figure out what is going on, including looking at, as Dr. Sadeghpour said, looking at the patient's past medical history to figure out whether they have anything that would contribute to that. The one thing I would say is that you really should know what you're going to do if you find something different on echo before you do the echo. So we probably shouldn't anymore be in this kind of, well, they've got a heart, they need an echo sort of way of thinking. We need to target our imaging, we need to target our indications, and we need to figure out how this is going to help us to elucidate what's going on with the patient. Sometimes, as Dr. Sadeghpour said, it might actually be very helpful to know that the EF is low and then it gets better in the clinical treatment of the patient. One thing Dr. Chertow actually mentioned in our preparatory session was some apparent similarities between what we're seeing in COVID-19 patients with myocarditis and CAR T-cell involvement of the myocardium. I don't know if you wanted to mention that here also, Dr. Chertow.
Sure, I'm happy to comment. I think my comment would start off with the idea that we're still very early on in this outbreak, and as we move forward, I think we're going to try to better understand not just the clinical manifestations of these diseases, but the molecular and immunologic correlates that will help sort of better guide best practice and perhaps targeted therapies. With that in mind, as Dr. Sadeghpour pointed out, there are case reports that raise the question of whether there is a non-ischemic cardiomyopathy component in some of the more severe cases. The answer is we don't know yet, but the question of either direct virally mediated or host mediated processes in the setting of an infectious or a non-infectious inflammatory process that might result in decreased myocardial function, either is certainly possible, either direct viral or host related. And as it relates to the cell therapy patient population, it is a known observation that in the setting of cell therapy, one potential complication is reversible cardiomyopathy, presumably, although without great certainty, attributable to an inflammatory milieu that has yet to be characterized if it's attributable to a cellular or a soluble mediator. So I think as we move forward, beginning to try to understand that better in this disease, what's happening at the pathophysiologic level and what interventions may or may not help are going to be fundamentally important.
I want to get to some more questions because we've got so many coming through, but I'll sort of segue from Jim's last point about scan time and targeted echo scanning. Given that we want to limit scan time, what is the role of ultrasound enhancing agents in this regard?
So certainly I think that there is a big role. They will reduce the amount of time that we have to spend to particularly look at wall motion. But the thing that I would really caution people to do is that the last thing we want is the sonographer going in realizing they need contrast and then having to wait either in the room or come out of the room, use more personal protective equipment while waiting for the contrast agent to come up. If you think you might need it, if you think you're going to need to look at wall motion and there's any chance that you're going to need contrast, you'd better go in with it. And this really should be the way that we think ahead in doing this in order to preserve our personal protective equipment and reduce our exposures. Now, of course, if the nurse has to inject it, that's one more person being exposed, but at least you can reduce the time that it takes to do the scan.
Yeah, some questions coming up on logistics, several questions before I dive into the cleaning and the personal protective equipment controversies here. So logistics, how do you cancel all elective echoes at this time? Do you cancel all elective TEEs? And how do you approach this sort of elective versus, this conserving of resources kind of thing? I'd like to hear from Jim and Anita, both from the Iranian experience and from the Seattle experience. Jim?
Sure. Right now, we are going through all of our special procedure requests, which we define as being stress tested TEEs, in the outpatient setting, and we essentially try to figure out which ones can be postponed safely. So, for instance, somebody that has a procedure that's coming up, and that procedure got canceled because it's elective, we certainly don't need to do the echo procedure, and we could safely postpone that until it's needed. On the other hand, there, at this point, are still some people that are on the transplant list. And if they don't have an ischemic workup, they may miss out on a graft. And so that, at this point, at least, we are still going ahead with stress tests on those particular patients. But we're trying to do this on as best and most respectful to the ordering clinician way that we possibly can, while also reducing the sort of elective exposure that we have. For inpatient requests, we are considering all of them very carefully as well. And again, trying to ask this question, could it be done later under better conditions? And what we're, again, using as our criteria is, if this person doesn't have this test done, are they at significant risk of death, significant morbidity or suffering, or are they going to access the healthcare system and use more healthcare resources in the next month? And if we say yes to those, then we go ahead and do the test. Now, of course, this is all subject to change, but at the moment, that's the standard that we're using.
Yeah, and I guess it also speaks to the conservation of resources, especially when staffing levels may go down. Anita, any experience from the Iran folks?
Yes, you know what? When the elective surgeries are canceled, some of the echo procedures will cancel also. So the patients should be asked just if the patients are symptomatic or no. Usually the patients who are asymptomatic can wait to see what will happen. So for a few months, we can postpone the TE patients for the valvular heart disease, and the stable, even the ischemic stable patients can be communicated with the telecommunication. These are good for both sides, the patients and the healthcare providers.
Right, great points both. What about logistics? And some questions have come up regarding follow-up echoes, like patients coming after watchmen who need TEEs, or patients coming in post-TAVR who need follow-up TTEs. Some of these, folks have put up questions that they were unlikely to be postponed. Should they be deferred?
We are deferring most of those. Obviously, if there are clinical signs or symptoms or something happened during the procedure that is concerning, we would take that into consideration. But hopefully, it will only be a month that these are postponed, and that shouldn't make any clinical difference. But again, I believe that we should try to consider these on an individual basis as much as possible.
Yeah, a couple of questions have come up on exclusion of certain personnel, and I think most of the questions have come in from echocardiographers or sonographers who may be pregnant, or some who may be over 60 years of age, or maybe immunocompromised. What is our position on exclusions from scanning, and what impact has that had on some staffing levels in your institute, either Anita or Jim?
Jim.
Well, we have not had a problem at the moment because our numbers of studies, because of the ones that we're not doing that are more elective, we don't have huge needs for staff at the moment, and that could obviously change if there are a lot of inpatients who need to be scanned in the setting of COVID infection or some other reason. This is, I think, a very fluid and dynamic sort of area that local practices are going to have to wrestle with. I think there are a lot of things that one can do, even if the official word from the institution is that people should continue to go to work and monitor for symptoms. There may be ways that certain high-risk individuals could do certain tasks that put them in a little bit less of a compromised position. But I don't know that there's any sort of right way to do this at this point, and we will hopefully know more very soon.
Anita, any experience from Iran on this?
Usually we try to not get help from the echo personnel who are pregnant at this time, or over age 60, or even immunosuppressed. So I think these are between the personnel, and the situation will differ. However, usually they are excluded from the work, but it is very dependent on the institute protocols. And sometimes they can use the N95 for these patients, which are more at risk for the COVID-19. These are the high-risk group. But I knew that they try to exclude these personnel from doing the sonographers, for doing the cardiac sonography.
Right. And how are we handling fellows in the echo lab or for TEEs or any of these echo studies? Jim?
We are trying to practice social distancing, so we're trying to run with as few fellows as we can manage. The other issue is that fellows obviously are also clinicians on the floors, and if our workforce is to be reduced, we certainly want to have people who are able to do primary care of patients as well as do echo lab things. So we're trying to carefully consider how to match our and preserve our workforce going forward. That said, I think education is still a very important part of what we're doing, and we need to be careful about completely putting that aside, because we will need well-educated and expertly trained people going forward.
Yeah, and now, you know, a lot of questions have come in on the issue of surgical mask versus N95 respirators, and I'd like to sort of delve into that, because we've made a distinction in our statement about airborne precautions and droplet precautions. And so a lot of echocardiographers are concerned that why don't we recommend N95 masks on all patients who are coming in for an echo and are either suspected or confirmed COVID cases. And so I think that has to do with the concern that if they are shedding, if they are posing a risk of transmission to healthcare providers, why shouldn't we recommend that everyone wear an N95 mask as opposed to a simple surgical mask? Jim, did you want to comment on that, or any of the panelists, actually?
Well, I think that I can't speak for the CDC. That is what we are recommending, is to follow the CDC recommendations. But I would just go back to something Dr. Chertow said initially, is that we have to balance all of the data that we have and our concerns with the issue of scarcity. We will not have enough personal protective equipment. It will need to be rationed unless something changes very quickly. Now that will change once we have enough, but at the moment we are facing shortages and we have to make some difficult decisions about that. I don't know if Dr. Chertow also wants to address that directly.
I think that's exactly right. And you know, again, these decisions have to be made by an institution to institution basis. The recommendations that are coming, again, I don't speak for the CDC either, but the recommendations that are coming out of the CDC are based upon, historical understanding about transmission patterns for other respiratory viruses. But we all know that this is a novel virus and we're learning about it as we move forward. Information is coming out and recommendations based upon historical information that we have for other viruses, as well as we're learning about this virus, are guiding recommendations. And those recommendations suggest that the primary mode of transmission are large respiratory droplets and not the small droplets. And it is true that the clinical and epidemiologic patterns of this virus strongly trend with that. In other words, it is not following an epidemic curve of measles. There's been modeling and estimates of the reproductive number of this pathogen, and it is closer to a pathogen that is transmitted by large respiratory droplets. So the recommendations out there are based upon historical evidence and what we're learning about this pathogen as we move forward. And understanding the balance between risk and scarcity is an important feature to keep in mind.
Right, and I think that's a critical difference that that we point out in the statement as well, that we want to also be mindful of conservation of resources, and if we treat everyone like they were airborne, risk for airborne transmission, we would rapidly deplete our resources, especially when we need them for the most aerosolization risk patients, and when we use things like N95 masks or PAPRs for patients who do not present an aerosolization risk. I guess the concern is that, is this a gray zone or is this a black line? And that is the problem that most people are dealing with. I'm going to ask one more question here, as regarding the cleaning of machines, and Jim or Anita or any of the panelists, do you recommend probe covers when doing a scan? And then what about cleaning of the entire machine? And how do we, not just probes and probe covers, but exactly the entire machine and screen? How do you approach those?
So it depends on the manufacturer. For sure, they need to have the confirmation any solution they use. But for the monitor, generally the alcohol shouldn't be used for the monitor. So they should be aware that the monitor is different, and with a soft tissue and soap, they have to clean the monitor. And for the other part of the plastic one, the cable one, they can use the alcohol. These are the general rules, but also they have to ask the manufacturer and guide from them. For any plastic type of the echo machine, they can use the alcohol 70% wipes. However, shouldn't spraying the connector. Some things are very important, not to spraying the connector side, and even the cable and the probe of transthoracic. First, they should clean it. The gel should be cleaned from the transducer, and then there is an intermediate level liquid even for the transducer for transthoracic echo. However, they can also use the alcohol 70% for 30 seconds on the probe and all parts of the echo machine. Just the monitor, alcohol is not good for the monitor. For the control panel, they also can use the alcohol with wipe. And let the white time, as Jim mentioned.
Right. I want to be mindful of everyone's time, and we've come to 8 p.m. So I'm really grateful to all the panelists for your participation in this very important webinar. I want to thank everyone who has been attending and asking questions on the Q&A panel. We haven't gotten to all of them, but what we will be doing is archiving these and putting a lot of these answers from our panelists. We'll post these to our panelists offline as well, and have these answers posted on our website under the Q&A section, under the FAQ section. So if your question has not been answered, I've tried to sort of categorize them and go through as many as possible. But if we haven't gotten to your specific question, I sincerely apologize, but we'll try and archive and answer as many as possible on the web page. So thank you everyone for joining. I am really grateful that you spent some very valuable time, and I hope it was valuable to all the attendees. So thank you so much.